And welcome to the first of a series of webinar hosted by the Filipino Nursing Diaspora Network in collaboration with St. Anthony's College, the Pacific Nursing Service Organization, and the World Continuing Education Alliance as our platform provider. At this point, we'll be listening to a short message by Dr. Patria Manaraysay, the President of the Pacific Nursing Service Organization.
World Continuing Education Alliance. A warm greeting to everyone joining us today. The Pacific Nursing Service Organization is honored to be part of this meaningful learning event that brings together nurses and healthcare professionals from across the globe. Our shared commitment to advancing nursing knowledge and improving patient outcomes knows no borders. Today's webinar on enriching nutritional status of ICU patients through early enteral nutrition is more than a lecture. It's an opportunity to strengthen our practice, challenge ourselves to ultimately make a greater difference in the lives of those placed under our care. We extend our sincere gratitude to Dr. Rizaldy Bandola for sharing his expertise, and to our dedicated event partners, the World Continuing Education Alliance, St. Anthony's College, and the Filipino Nursing Diaspora Network for making this collaboration possible. Together, let us continue to inspire, empower, and innovate for the future of nursing in the Pacific and beyond.
Thank you, Dr. Manalaysay, for your inspiring words. Now let's listen to Irene Mayo, the FiND Network's Director for Engagement, for her message.
Welcome, everyone. I look forward to this presentation, and I'd just like to acknowledge on behalf of the Filipino Nursing Diaspora Network, a great big thank you for the collaboration with the World Continuing Education Alliance, as well as St. Anthony's College to bring this session together. It's amazing to see almost 400 participants in this webinar, and I think that just shows how topical this critical topic is. In critical care, time and precision matter. Early enteral nutrition isn't just about calories, it's about preserving gut integrity, modulating inflammation, reducing complications, and supporting overall good recovery. Today is about translating evidence into practical bedside decisions that improve patient outcomes. We are very honored to be joined by our speaker, Dr. Rizaldy Bandola, who will bring rich frontline experience and a passion for elevating ICU patients' experiences. Again, on behalf of the FiND Network, thank you for coming here today and investing your time with us. Your commitment to learning and professional development is a testament to you as a bedside nurse. So let's dive in. And again, thank you so much, Dr. Rizaldy, for spending your time with us this Saturday.
Thank you, Irene. And I turn back the floor to Sam.
Thank you so much. Thank you, everybody, for joining us today. Thank you for the wonderful introductions and presentations. It's wonderful to have everybody here. As Irene said, we have over 400 people in the room, which is wonderful. So I would just like to welcome everybody to today's webinar on enriching nutritional status of ICU patients through early enteral nutrition. Brought to you, as they've mentioned, by the Filipino Diaspora Network and the World Continuing Education Alliance. My name is Samantha. I work for the WCEA, so I'll answer any technical questions you may have in the chat. And please, if you have any questions for our speaker today, please use the Q&A section, and we'll try to get to them towards the end of the presentation. Okay, so for those joining us for the first time, again, the WCEA is a social impact technology organization dedicated to using digital tools to help healthcare professionals grow their skills, improve care, and support healthier communities worldwide. So we thank you so much again for joining us through the network and coming to the webinar today. With that said, I would like to hand it over to our esteemed speaker today, Dr. Rizaldy Bandola. Dr. Rizaldy Bandola is a highly accomplished nurse professional with a strong academic and clinical foundation. He earned his Bachelor of Science in Nursing, graduating magna cum laude in 2008, followed by a Master of Art in Nursing and a Doctor of Nursing Practice degree with distinction in 2023. Dr. Rizaldy currently serves as a clinical nurse education specialist for the critical care and a clinical instructor for AHA's BLS, ACLS, and PALS courses. He holds a CCRN certification from the AACN and is a certified ECMO specialist through both the ELSO and American Society of Extracorporeal Technology. Thank you again, everybody, for being here and investing in your professional growth. So I'll hand it over to you, Doctor. Let's get started.
Thank you so much for that introduction, Samantha. And I would like to share first my slides to all of you. Okay. Can you able to see my slides right now?
Yes,
Yes,
slide is visible.
we can see
All
it
right.
perfectly.
All right. Hi, colleague. How are you all? I know it's 10 o'clock in the morning, Philippine time. And here, those who are attending from the North America, including Canada and here in the United States, have a good evening to all of you. And I know it's past 10 a.m. and I hope that you are not skipping your meals. You have to take your breakfast every day because that is really an important meal every day as it jumpstarts our metabolism and it also helps to provide us sugar from our overnight sleep. It helps to boost our cognition and to help us having a concentration, particularly in our day-to-day event, such as this, a knowledge sharing event for our webinar session. And I would also like to take this opportunity for the organizer, Filipino Nursing Diaspora Network, and the rest of the people behind it for giving this platform to share about the important nursing intervention to help our patient population through the provision of nutrition, particularly to those patients who are experiencing a critically ill condition. So, as a disclaimer, this presentation is intended only for educational purposes only. Whatever specific products or any commercial entities, I am not recommending nor endorsing it. It is just only for illustrative purposes, and moreover, I don't have any relevant financial relationship to disclose. So, when someone is acutely ill, it is really common to see a drop in appetite. But this is not just a side effect or something in their head. Actually, it is driven by the important hormonal changes happening inside the body, and that is the peptide YY hormone uh, and the ghrelins. These shifts dramatically during an illness, wherein the ghrelin, supposedly the appetite stimulant, usually their level drops during an illnesses, wherein the patient having a reducing to desire or reducing the desire to eat. And the peptide YY during an illness usually rises, which furthers dampening the appetite of our patient. This hormonal shift is part of the body's natural responses to acute illness, steering energy away from eating and digestion and their focus on healing. And on top of that, those patients who are experiencing a ailments such as heart failure, the patients who have a lung injury, kidney failure, those who are having a liver disease, and those patients who are developing sepsis. These causes an inflammation, and this inflammation releases the chemical mediators that we call as cytokines. These cytokines cross the blood-brain barrier that tells the brain to suppress hunger even more. Actually, when the patient is admitted into the ICU and their disease condition is further exacerbated, uh, the effect of reduction of appetite is even more amplified due to the severity of the illness and the increased inflammation or inflammatory markers that triggers to what we call as the sick response, wherein the body's priority at that moment is to fight an illness and not to eat food. According to the study of Van Vliet, around day 10, between day 5 to day 10 of hospitalization, many patients start showing signs of malnutrition due to the combination of the reduced appetite, increased energy needs, and the poor intake. And understanding this cycle is key because it explains why the early intervention for nutrition support is essential in critical care. So, what are the challenges in provision of nutrition in the ICU? First, the poor nutritional intake is a problem on its own, but it gets worsened when there is a suboptimal delivery of nutrition in nursing care. Plus, the fact that there is an over-competing priority in the ICU, such as most of our focus is to take care of the patient on ventilation, providing the medication, tapering and titrating it to save lives, the turning schedules, monitoring the vital signs, and all of these things wherein the nutrition is usually oversight and the heavy nursing workload. This is usually happen wherein it is a major limiting factor in the provision of nutrition. Usually the nurses are stretched thin and with limited time and high stress environment, and the nutrition is always not being prioritized. And here's an important insights from many studies. According to them, many nurses are not fully aware of how critical nutrition is for patient recovery. Actually, it's not about the neglect, it's about the lack of emphasis in training or reminders about the importance of nutrition to our patient. And at this point, I would like to know your insights, and I want you to participate uh, through our comment section. Please write down in there one or two benefits of the nutrition for our patient, and I will try to read it later. Okay. And there's one more critical point at this time. In many ICU, there's simply a lack of reminders. We don't have any prompts to ensure that patients get their nutrition on time unless there is someone who is checking and the feeds cannot be delayed or missed completely. That is why there is an increasing prevalence of hospital acquired malnutrition. Malnutrition in the hospital, particularly in the ICU, is very prevalent. In fact, the study suggested, and according to the statistics in the global perspective, it's about 50% to as high as 78% among our ICU patients are experiencing malnutrition. That's more than half. Sometimes nearly 8 in 10 patients are experiencing the malnutrition. And also, those who are having or not having malnutrition prior to the hospitalization, they may develop malnutrition through time because we are not usually prioritizing these types of nursing care delivery in our patients in the hospital. And it is being under recognized and under treated, which causes a serious consequences later on to our patient, wherein they might have a higher risk of complications. They often experience longer hospital stays, experiencing a poor wound healing and higher rates of infection, particularly the hospital acquired infection. And according to the Agency for Healthcare Research and Quality, people who gets malnourished or who is experiencing a malnutrition have a higher risk of readmission after discharge. There is a mechanism wherein there is no food in the gut. The bacteria can move from the intestines into the bloodstream, and that is what we call as the translocation of these bacteria, causing an increased risk of infection and developing the sepsis. So it is important that we have to use the gut when we are providing the nutrition to our patients. And also, when the patient is having a malnutrition, it drives up the healthcare utilization and costs. So it is not just a patient care issue, but it's also an organizational burden as we are increasing our budget utilization when we are treating our patients who are experiencing malnutrition. Speaking of malnutrition, prioritizing the nutrition means prioritizing patient safety. In many busy hospitals, such as in the ICU, nutrition is usually being delayed because of, as I have mentioned, the over competing priorities and the high workload, and everything is being urgent to save lives. But here's the problem: when the nutrition is being delayed, we can unintentionally causing harm to our patients because those patients who are not receiving an adequate or timely nutrition, they are at a higher risk to develop an infection. They also develop the muscle wasting, which contributes to the longer ICU stays or even more hospital stays. So by postponing the nutrition, even for just a day or two, we are affecting the patient's recovery, the patient's immune system, and the overall outcomes. Actually, the nutrition is a recognized patient safety standards as most of the regulatory bodies, such as the Joint Commissions, is emphasizing this nutrition as a mandate when the patient is being hospitalized. They are integrating the nutrition in the nursing care planning, and it is a must and it is a mandate that we have to screen all of our patients admitted for nutrition at risk within 24 hours of admission and initiate the multidisciplinary intervention, including the dietitian and the physician, the nurses, when we are providing the nutrition care or as part of the treatment plan of our patients. The important role of the nurses in helping our patient to boost their nutrition is always as one of the frontline health worker is to complete the initial nutrition screening. so that we can able to identify who are at risk and who will provide or who needs to receive the more comprehensive nutrition intervention. And it is also important to notify immediately the rest of the care team for the timely action. Again, this is not an optional step, but it is our core responsibility. There's also a professional bodies like the American Society for Parenteral and Enteral Nutrition, together with other global critical care societies. They recommended that the nutrition must be provided within 24 to 48 hours upon patient's hospitalization or having resuscitated or intubated, post surgery, or being admitted in the ICU because it has an impact to patient safety and improves patient outcomes. According to the evidences, early enteral nutrition leads to an improvement of gut integrity and the immune function. It causing the fewer infection rates and lowers the risk of the organ failure. Early enteral nutrition also helps to shorten the ICU and hospital stays and even reduce the mortality rates. So, when we are prioritizing the nutrition early, we are reducing the harm, we support healing, and we can save lives. So, it is not, nutrition is not a clinical decision, but it is a patient safety mandate. Every hospital sets a key performance indicators to measure and to drive our intervention towards the positive patient outcomes and safety. And these indicators helps to track down how well we're doing and where we need to improve. And I believe that most of you nurses and the student nurses, there is what we call as care bundles. These care bundles is the standardized best practice that helps to build of reducing the certain parameters such as prevention of ventilator associated pneumonia, prevention of central line associated bloodstream infections, and also the prevention of catheter associated urinary tract infections. There is also the care bundles to prevent the occurrences of pressure injuries. Most of the key performance indicators are focusing on these uh, usual ICU occurrences that we could be prevented. There's also care bundles to reduce the ICU length of stay. Although all of these are being monitored and there's a lot of strategies that we are doing inside the facility, particularly in the ICU. Actually, our current numbers in the organizations where I am at shows an improvement, but there's still an existing numbers of hospital acquired infection, which means there's still room to grow. So, upon conducting our unit need analysis to conduct the quality initiatives as we identify the care gaps, one major area that my eyes focus on, and that is the provision of nutrition. So at first, we develop the practice question that uh, requires an answer that is measurable and aligned with the hospital priorities. We thought about the translation of this evidence-based practice into action by answering this definitive practice question among adult patients admitted in the medical surgical ICU. What is the impact of the implementation of this 2021 ASPEN guidelines compared to our current practice, which means uh, we are translating the feeding of our patients within 24 to 48 hours from the time that they are being admitted into the ICU or from the time that they are being intubated from resuscitation. And we have performed it, we have tested it for the over the 8-week period. However, it is important that we have to assess first before we perform an intervention. In fact, there is no gold standards in nutrition screening tools to assess the nutritional status at this moment. Instead, I am showing you in the slides the examples of the nutrition screening tools that you may able to apply to assess the nutritional status. Historically, the clinicians uses the visceral protein, which is the albumin and pre-albumin, to measure the nutritional status. Also, they are utilizing the anthropometric measurements such as the weight and the body mass indexes. However, for the critically ill patient populations, these are not reliable. Reliable because there is an inflammation, there is an immobility, and there is a hypercatabolism when patient is too much sick, which distort these values and making it more or less accurate when we are measuring it. So given this nutrition screening tool I have provided you, it says that it must need to be simple and easy to perform at the bedside, so the nurses must quickly identify who are the patients at risk to develop the nutrition malnutrition. In the organizations where I am at, we are using the malnutrition screening tool because it is more straightforward. We are asking whether the patient experienced the recent weight loss for the past days, for the past week, and if the patient developed the recent poor nutrient intake in the past few days. So it is more straightforward. We can easily assess and identify the nutrition at risk at the from the time that they are being admitted in the hospital, and it must be done within 24 hours of admission. Remember, nutrition screening is the crucial first step because without it, the timely nutrition intervention might be missed, which can impact the patient recovery. So, I have uh, I have here in my slides the example feeding algorithm that uh, every facility can utilize. However, it is the primary responsibility of the dietitian to provide a more comprehensive nutrition for each patient. And when it comes to feeding via the gut or the gastrointestinal system is more preferred route. And because it helps to maintain the gut integrity and supports the immune system. However, there are an important exceptions that the enteral feeding is contraindicated to some of the certain conditions if there is an intestinal catastrophe, such as those patients who are experiencing a small bowel obstruction or bowel ischemia, or recent gastrointestinal surgery due to trauma or any other disease condition. In addition, we must also be cautious when we are initiating the feeding to our patients who have experienced a prolonged starvation. We have to be more careful to recognize early the signs of refeeding syndrome. The refeeding syndrome, it is really a life-threatening condition which characterize a dangerous shifts of fluids and electrolytes causing patients to die. So before you initiate the feeding, it is really important to assess your patient and the hallmark sign that you need to watch out for prior to the initiation of feeding from the prolonged uh, starvation. You have to check for the phosphate level. If there is a low phosphate level or hypophosphatemia, do not initiate the feeding because it leads to more serious complications or even death if not recognized early. And again, I am showing you the algorithm. It could guide you to provide a safe feeding practices uh, for nutrition or for the provision of nutrition. And you have to collaborate and coordinate with the registered dietitian on duty because they are the one that recommends the appropriate nutrition based on the comprehensive assessment or total patient's clinical status. Are you familiar with tropic feeding or the trickle feed? Tropic feeding or trickle feed is a gentle way to initiate the enteral nutrition, especially especially during the early phases of the critical illness. The purpose of this trickle feed is just to stimulate the digestive function, the digestive tract, and keep the gut working properly. Importantly, it helps when there is a food in the gut, it helps to prevent the bacterial translocation, which reduces the risk of hospital acquired infections. Normally, the provider or the doctor orders to start the feeding by 10 ml per hour and increase the feeding rate by tens or twenties every 8 hours as long as the patients tolerated it until reaching the target calories. And the target calories must be achieved within 3 to 7 days. Typically, the order must be gradually increased according to the patient's tolerance. So among this choice of feeding regimen, there is a continuous feeding, cyclic feeding, and bolus feeding. The most preferred uh, feeding regimen for the critically ill patient populations is the continuous feeding because it delivers the trickle feed, but with the use of the feeding pump. And it offers the more better gastrointestinal tolerance and the glucose control over time. However, the cyclic feeding, the nutrition is being delivered within the scheduled breaks. This approach is really helpful to promote patient mobility when we are assisting them to get for ambulation and improve more comfort when we go to the toilet. They can able to do it without bringing the feeding equipment in the performance of their daily activity. And the next is the bolus feeding. Bolus feeding, it involves the giving the nutrients in a larger amounts via a syringe pump or via a syringe or the aseptic syringe via gravity. It is common for patients with PEG tubes and is more convenient because it resembles normal meal patterns. I remember when I was practicing in the Philippines, we are not using any feeding pump, but we are giving the nutrients of our patients through bolus feeding, either Q4 or Q6, and that is the volume based nutrient delivery. Excuse me. There are different ways that the early nutrition can be delivered to our patients. The enteral nutrition or the well, the enteral nutrition can be provided through several routes depending on the patient's condition. And the most common and the straightforward method is through the nasogastric tube, wherein the tube goes through the nose into the stomach. But evidence suggested that in the critically ill patient population, the post pyloric route is more beneficial, such as through the nasoduodenal or nasojejunal tube. Why? Because it helps to reduce the regurgitation. It helps to develop the vomiting or any gastrointestinal tolerance, which is these are the common challenges with feeding the critically ill patients due to several factors such as immobility. You can also give the feeding through the PEG tube or the gastrostomy tube, wherein there is a surgically placement of this tube directly from the abdomen to the stomach. And this is commonly used for long-term feeding. However, the post-pyloric delivery of the nutrition, they may also give it through the jejunostomy tube, wherein the tube is being placed from the abdomen towards the jejunum or part of the small intestine. So, selecting the right delivery route and carefully advancing the feeding rate are usually the key to successful enteral nutrition and to achieve the target uh, patient's calorie. In 2023, there is an existing best practice to promote the early enteral nutrition among ICU patients, and also it is based on the recent evidence and guidelines. These supports the starting of the enteral feeding early, which has been shown to better patient outcomes and even increase hospital revenue due to reduced complications and shorter stays of our patients in the hospital. This has been made by the team of Bar Horse in 2023. They also recommend that these best practice is an evidence-based from the evidence-based guidelines that recommends to initiate the enteral nutrition within 24 to 48 hours of ICU admission, resuscitation, surgery, or intubation. There are numerous studies back this timing, demonstrating the faster recovery and fewer complications like the infections or muscle wasting. And to help me make this happen, as I performed the translation of this evidence base, and it is through the translating this nurse led alert system. We use the feed me sign, which is printed. This is printed in an A4 sheet paper, laminated it, and place it in each patient room. This is how it looks like. This is the visual prompt that serve as a constant reminder for the entire care team to prioritize nutrition orders and timely feeding. In coordination with the multidiscipline and the support of the organization, it drives to ensure that the nutrition is not overlooked despite of many priorities in the ICU. Actually, this card is what we called it as the nutrition cue card. We developed this nutrition cue card as part of our tool to prioritize the nutrition delivery in ICU. We use the Also, we use the NPO sign, the enteral feeding, and the TPN or parenteral nutrition. These cards are being placed in the visible location in every patient's room, serving as a quick reference for the care team about the patient's diet. However, if there is no nutrition order is not yet in place, it is the nurse decision. It is a nurse-led involvement to place this feed me sign in the visible area of the patient's room to prompt the team to address the nutrition immediately. Actually, this approach not only helps to encourage the timely nutrition interventions and early enteral feeding, but it also keeps the nutrition visible and top of the mind of the whole team. It supports the communication, and this is the most important for our young nurses. It helps it helps them to participate confidently during the treatment discussions when they are doing the rounds. It boosts their confidence as well. In short, this nutrition cue card bridges the gap between the awareness and action when it comes to nutrition. This intervention revolves around the early enteral nutrition. It was applied to all patients admitted in the medical surgical ICU for an adult population, wherein the early enteral nutrition quality project occur. However, there are some clinical situations where enteral feeding is contraindicated, and by following the policy of our organization, which is when the patient is having a small bowel obstruction, bowel ischemia, and a recent GI surgery. It is also included that we are preventing the patients to get feed when the patient is on high dosage of vasopressors, noradrenaline, norepinephrine, dopamine, because these vasopressors is uh, having an increased risk to develop the mesenteric ischemia. However, using the norepinephrine or vasopressor alone is not a strict contraindication. But when it is in a higher dose, that time that all the blood circulates, focusing on the vital organs, wherein it causing the bowel ischemia. However, to ensure we're the following best practice, we use a simple monitoring metric. We use the timing in hours from the time that patient is admitted to ICU or intubated to the start of the enteral feeding, so that we may able to monitor that we are following the 24 to 48 hours time frame of the provision of the enteral nutrition. Next, we will look on how these data is being used to track down our ICU performance indicators by showing you these results. Actually, when I analyze the data of our organization before any formal intervention, well, I am not surprised, but even without having any prompt, we are already following the recommended 24 to 48 hours window of initiating the enteral nutrition because of the average feeding time was 45.14 hours. That's within the range, but it's still toward the upper end. But after we implementing the structured evidence-based practices including these nutrition cue cards, having a nurse-led alerts, and collaboration with the multidiscipline. The average time or average enteral nutrition time drops significantly to just 26.69 hours. Well, that is nearly 19-hour improvement and getting patients feed earlier and more consistently. Actually, this was not just a time metric. The change had a significant impact on the overall patient outcomes and KPIs. Guess what? During this time, it helps to supplement our key strategies to improve our key performance indicators. Our ventilator associated pneumonia and catheter associated UTI rates drops to zero. And the ICU length of stay also decrease, and the overall uh, key performance indicators improve. And in fact, the study of bar horse stated that it reduces these several complications, and our result aligned with what we see in their published literature that supporting the early enteral nutrition. This just goes to show that even when we are doing well, the structured evidence-based interventions can always drive our performance to the next level. So this nutrition cue card played a key role in helping our nurses to meet the 2021 Aspen guidelines, specifically the recommendations to start the enteral nutrition within 24 to 48 hours of ICU admission. But it was especially encouraging to see the high compliance with this early feeding window after we instituted this nutrition cue card. This shows that when nutrition is made visible and actionable, the nurses can effectively integrate into our workflow. So the visual cue card or the nutrition cue card is really an important tool to prompt and prioritize the nutrition delivery for our patients. However, as we perform this translation of evidence, there are barriers that we have been noted causing the delayed delivery of the nutrition. One of those is the unavailability of the feeding formula, causing the delayed of delivery of feeding. Another preventable delay occurs during the time is the absence of prompt, because no one reminded that the patient is go beyond the 24 to 48 hours window of receiving the nutrition as recommended by the Aspen or American Society for Parenteral and Enteral Nutrition. But this is the big one, that problem. The placement of the nutrition card in the electronic medical record beyond 48 hours of admission. Because if there is no documented order in the patient's chart, nurses unable to carry it out and the feeding cannot begin. Remember, documentation always serves an essential purposes, because it tells the team what type of nutrition is being required. Without having a documented nutrition order, nurses will be confused and nurses unable to initiate or to start the nutrition of our patient. Also, the documentation of the nutrition order triggers the timely action of that intervention. So, it is about the communication and the process. For early enteral nutrition to happen smoothly, We need all these pieces in place. We need to have always an available feeding products on hand. We have to utilize the nutrition cue card as the prompt, and there must have a clear and documented orders for the nurses to carry it out. So how nutrition cue cards empowers nurses to be active advocate for early enteral feeding? The cue cards, because it acts as a visible and glance reminder for the care team to prioritize the nutrition alongside other critical intervention. If there is no nutrition order is in place, nurses has the power to put these feed me signs so that to alert the treatment team to place a feeding order without delay unless contraindicated. And when nurses actively participates in the treatment rounds, they help keep the nutrition on radar because they are the one who will discuss about the nutritional status for their patients, and it must be prioritized as part of the treatment plan. And with that, we can able to advocate the nutrition, especially early in the ICU stay. And if the standard feeding formulas are not available, rather than delaying the feeds, we can always ask the dietitian. We can collaborate with them, and so that we can start the tropic feeding or tropic feeding within the specified time, and the nutrition cannot be delayed. But the bottom line is the nutrition cue card is more than a sign. It is a daily tool for communication, accountability, and action. We have to use it consistently because it helps to ensure that the early enteral nutrition is not delayed even when there is any challenges arise, such as any occurrences happening in the ICU. And as we wrap up in our today's session, let's come back to the core message of this entire presentation, that early enteral nutrition saves lives, and it starts with us. Starting the early enteral feeding within the 24 to 48 hours of ICU admission is not just a guideline, it is a proven strategy that protects the patient's gut and enhances patient safety as well as to improves the patient outcomes. Why it matters? When nutrition is started on time, it helps your patients to recover faster. And by consistently following the evidence-based guidelines, we able to improve our compliance and reduce the complications and lowers the risk of the malnutrition related condition, which directly affects both clinical and our organizational performance. In prioritizing nutrition is one of the most powerful ways that we can support recovery and to provide a high quality care among our patients. And with that, I would like to thank you all for your time and your engagement and the dedication to improving patient care. I would like you to take a moment to scan this QR code with your phone's camera, and it will direct you to a very short survey. It's just a few quick questions for me to know your thoughts about the early enteral notation. And if there is any question that comes to your mind, please let me know and write it in the comment section. Thank you all.
Thank you, Dr. Bandola. That was a very interesting presentation. I think everybody's been enjoying it. I'm not sure if you're seeing on the screen all the little emojis that everybody's sending you of clapping and little hearts. We do have some time for some questions if you'd like to answer some.
uh, when to start feeding after ICU admission. So you can able to start the feeding unless contraindicated immediately once the patient is being admitted. But take note, most of our patients being admitted in the ICU requires mostly high pressors, high norepinephrine, high noradrenaline. We should have to avoid those feeding yet because it will contribute to the mesenteric impedance of the mesenteric circulation causing the bowel ischemia. So once you lowers down the noradrenaline, you have to inform the provider and advocate the nutrition. There's also a question here. Is there a tool that nurses can use in surveillance, assessment, and diagnosis of the nutritional needs of a patient in ICU? Yes, I have included in my slides the several example of the nutrition screening and should be done within 24 hours from the time that they are being admitted in the hospital. And also, the more comprehensive assessment, it should be done by the registered dietitian. Once you screen your patients to be nutrition at risk, you have to inform the physicians right away, and you can able to collaborate. No, not you can. There will be having a collaboration with the registered dietitian to perform more comprehensive nutrition assessment, which wherein no dietitian to compute. It's combination of fruits, eggs, and milk on a blender. It is the recommendation from the registered dietitian, which is the best for giving nutritional needs if unable to feed himself through NGT or TPN. Thank you. As per the evidence, the important route that provides the better outcome if we are providing the nutrition through the gut, and the post pyloric route is more beneficial than the nasogastric tube. The post pyloric, it should be beyond the stomach, which is through the jejunum or duodenum, because it reduces the regurgitation, it reduces the aspiration, and it reduces vomiting and gastric upset. How can we nurses and dietitians collaborate to ensure timely initiation and monitoring of early enteral nutrition? There is a system wherein upon a patient's admission, the nutrition screening is being performed by the RN and immediately notify the registered dietitian, uh, especially those who are positive for nutrition at risk, so that they can able to do the comprehensive nutritional assessment and recommend the most appropriate nutrition for the patient. How might the approach differ for patients with chronic eating disorder and for this living with a long-term colostomy, considering their unique nutritional challenges and risks of complication? Early enteral nutrition. The contraindications for and the only contraindications to perform the enteral nutrition if there is an intestinal catastrophe, if there is a bowel ischemia or small bowel obstruction or the traumatic bowel surgery or the bowel surgery caused by trauma. These are the contraindications that uh, might be a challenge to provide an enteral nutrition. However, patients with colostomy, as long as the gut is functioning well, you can able to provide this enteral nutrition. What is the essential steps once you start feed and the patient shows gagging, uh, it seems like that it is related to the patients who are experiencing stroke. So, nasal or enteral feeding route is beneficial to assist our patients to receive the patient nutrition. However, it, evidence also suggested that utilizing the patient's physiological way of eating to helps more patients outcome, and there is what we call the dysphagia screening. We can able to perform that by using the 30 ml of liquid. uh, you have to assess your patients to drink it all one time. And if the patient develops some cough and also experiencing throat clearance, it means your patient is failed and you should not uh, provide the nutrition through mouth yet.
Dr. Bandola, we may have time for one more question, and then we have to wrap up, okay?
Okay. Beyond weight and laboratory values, what bedside assessment are most predictive of enteral nutrition efficacy in critically ill patient population? Normally, the weight and laboratory values and the hemodynamics and the overall clinical status of the patients will be the predictive measures, the effectiveness and of the nutritional interventions for our patients. And I hope that I able to answer all of your questions. But I would like to express my gratitude to all of you and my appreciation for having an interest to our topic today.
Thank you so, so much, Dr. Bandola. Everybody has been enjoying the session. Everybody's clapping for you. Everybody has been saying thank you so much while you were reading the questions. It was so brilliant to see. We actually had over 680 people we have on online at the moment. So thank you so, so, so much. With
You're
that
welcome.
said, before we continue, I'd just like to ask everybody to turn their cameras on, and we'll take a quick screen cap. Oh, let me make sure my camera's working. Okay, and we'll take this quick screen cap. I'm not sure if there we go. We'll take a quick one. Just give me 1 second. Smile, everyone. Wonderful. Great. Thank you, everyone. That's perfect. And I'd like to thank everybody for joining. I'm not sure if Jerome or Iris would like to add anything before we finish the session today.
I can give a closing remarks then.
Be my
Okay.
guest.
Thank you so much, Sam. Magandang umaga sa inyong lahat. Magandang hapon. Thank you, Sam, for facilitating this webinar. Today's webinar, a landmark event for the Filipino Nursing Diaspora Network, was a powerful testament to the impact of collaboration with nearly 700 nurses from across the globe in attendance. We not only celebrated the power of knowledge, but also affirmed our collective commitment to advancing patient care. Dr. Rizaldy Bandola's insightful lecture on early or enteral nutrition was more than an academic exercise. It was an urgent call to action. He emphasized that nutrition is a therapeutic intervention, one that nurses are uniquely positioned to deliver and monitor. His expertise provided us with actionable strategies to reduce complication and accelerate recovery for our most vulnerable patients. The overwhelming response from participants and the pride of our partners, St. Anthony's College of Antique, under the deanship of Dr. Aris Bungabong, the Pacific Nursing Service Organization under Dr. Patricia Manalaysay, and the World Continuing Education Alliance, highlighted the hunger for advanced education within our nursing community. This event bridged the gap between theory and practice, inspiring a renewed sense of purpose and a determination to implement evidence-based care more rigorously in our respective units. As we conclude, let's carry the lessons learned today back to our practice settings. The ripple effects of this single webinar will undoubtedly be felt in your ICUs and hospitals in the Philippines and across the globe. Maraming salamat for joining us in this journey to empower nurses and build a brighter future for global healthcare. Next month, we will have another webinar, and then all through December, we'll have a monthly seminar.